you can all read about Christina. You all know her. There's a handout with her picture on it, and I'm going to tell you a story instead. About 5 years ago, it was raining in the desert, and I was at a meeting, and I opened up my door for my little casita, and fully expecting to get soaking wet going down to the conference center. And just as I open the door, I see there's a covered golf cart there with Christina and her nurse. Now, I didn't know Christina at the time. Never met her before. And I just said, hey, you guys, can you wait for me? I need a ride down there, too. And it turned out that they were going down there. It's only about 5 minutes. By the time I got down there, instead of you guys, I was saying you all like the best of you. And later that evening, we ran into each other and talked a little bit at the bar, of course. And she started telling me about all her plans to have this great headache center, and she was going to run it by herself and get as much help as she could from other people. And it sounded like a great idea. And over the course of the next few weeks, we communicated quite a bit by phone and by emails. And she started telling me about all these hassles that she was getting, people putting roadblocks in front of her to prevent her from doing it. But she sounded more and more determined every time I spoke to her. And whenever I have a young patient, particularly a female patient, who's having problems getting started in their life, I always use Christina as an example. She has become one of the real true rising stars in headache medicine. But more important, she's one of my best friends. So here's one of the best people you could hear talk about this topic.
Okay, let me get started. So I was going to do the boring, what is migraine? Let's treat migraine. How do we treat migraine? And it is boring. I actually love cluster headache, Ashley. But it's very important because we have so many patients who have migraine who are not getting the correct diagnosis. And I think all these guys already stole all my stats. But migraine is very important to me because at the Headache Center, 80 to 90% of what we treat is migraine and even chronic migraine. But the key to getting them the best optimal treatment plan is diagnosis. So we're going to start there. These are my disclosures. I'm following in Bake's footsteps. If anybody else wants to pay me, please go ahead. I have 4 children. And then these are the objectives. And, I haven't finished my PowerPoint because I've been busy with this, so the references and other things will be coming later. I'll have some more pictures in it by next year. So here's my prevalence and burden slide. Oh, I thought I had more on there. Okay, maybe I didn't save that. Okay, but I know it. So 36 million Americans have migraine, and that's about 12% of the population. And the proportion is after puberty, more females have migraine than men, about 3 to 1. But actually before puberty, boys have it like 1.5 to females. So, and 10% of children have migraine, and they go undiagnosed all the time and certainly undertreated. Billions of dollars are spent every year on headache, not only headache, healthcare utilization costs like pharmacy and going to the provider, but even more money is spent with presenteeism and absenteeism from the employers. Let's see. All right, so this is the criteria for migraine without aura, and I go and speak about with these pharmaceutical companies about migraine almost every week, if not twice or 3 times a week. And honestly, a lot of people just do not know what the basic criteria is for diagnosing migraine. It's very important, but some of my colleagues would probably agree with me that if a person leaves their office or their home, they make an appointment with you for recurring headaches, it's migraine until proven otherwise. It's not sinus headache. Ann Calhoun, she's not in the room right now, but Ann Calhoun's speaking tomorrow on menstrual migraine. She's the menstrual migraine guru. We have like 6 of her articles, and she's amazing, and I went and rounded with her. But she says that sinus headache is the street term for migraine. And actually, this criteria is from the International Classification of Headache Disorders, and in other countries, they don't even have a term for sinus headache. There is no such thing. So what is migraine? Now, in your history, you have to have a history of at least 5 of these recurrent episodes of head pain, but there's other things involved. So what if somebody comes to you and they've only had 3 episodes in the past of these headaches? Well, that would be considered probable whatever you're going to diagnose. So their headaches have to last a minimum of 4 hours, treated or untreated. But the way we ask the questions when the patient's sitting in front of us is not so cut and dry like this. A lot of times you'll say, how long do your headaches last? And I'll say, 2 hours. As soon as I take that BC, it's gone. And so you have to say, if I took all your medication away from you, how long would that headache last? And then you have to have 2 of the following. You either have to have unilateral location, but I think this is one of the least important things because migraine can be anywhere in your head, face, and neck, and only about 60% will report that it's unilateral. And unilateral, I think, happens more when you're in episodic migraine, and once you get to chronic migraine and you're got the central sensitization, people have generalized head pain and neck pain. Pulsating quality. This is another one I think that's not very important for the criteria because sometimes they'll say it's pulsating, but migraine can be described any other way. Pounding, pressure, it can be stabbing. It doesn't have to be pulsating. The things that really set migraine apart is it's going to be moderate to severe. Nobody leaves their office to make an appointment with you and leaves their job and their kids if they're tension-type headache should never be diagnosed in any clinic because nobody, if it was a mild to moderate headache and it was easily taken care of, they wouldn't be coming to see you. And then aggravated by activity, and you've got to ask this question the right way. If you just say, read it off the slide, they're going to say, oh, no, activity doesn't bother me. And so I'll ask them, so on your worst headache, when you say it can get up to an 8 out of 10, and if I told you to run up the stairs or do a cartwheel, would that hurt? And they were like, I would never do that. So you've got to ask the questions the right way. So you've got to spend a lot of time with these patients because we've got to ask them the right way. And then one of the 2 following, nausea. Got to ask this the right way. 70% report nausea, but people don't understand that word in different rural populations. And so you'll ask a patient, do you get nauseated with any of your headaches? And it doesn't have to be every single headache. It's with any of your headaches or your worst headache. And a lot of people will say, no, I never vomit. Well, I didn't ask you if you vomited. Vomiting is only 29%, and it's not with every single attack. So do you ever avoid food when you have a headache? So it's really important to dig deep. This is like the most important slide. It's the most boring slide, I hope. But it is very, very important. So it's how you ask these questions. It's why we spend an hour to 2 hours with all of our patients. It's why I only allow my nurse practitioners to see 15 to 20 headache patients per day because we spend so much time getting the right history and then making sure that we spend the time on the back end doing the patient teaching, which is the most important part. Sensitivity to light and noise. A lot of patients say, no, I don't have that. And you say, oh, so if it's sun shining, you've got to go to Johnny's game and your head's pounding and it's at 8, that would be fine. So you've kind of got to put it into their terms. Also, people will say they're not sensitive to sound. I said, what if I came with my son's tuba behind you and played his tuba? Would that hurt your head? That would exacerbate the pain. And then Bake mentioned osmophobia, which is a good one, which is, smells are more offensive than anything, and the certain odors can actually cause more pain. There are also things on this slide that are not on here that should be here, and I'm going to go into those things. And then not better accounted for by another diagnostic criteria. That's where the SNOOPS comes in and Heather's talk comes in, and I will go over the SNOOPS as well. But this information comes from cephalalgia. And they did the diagnostic criteria. They reevaluate it like every 5 years. And so this version, the International Classification of Headache Disorders 3, just came out in January of 2018. And I think everybody should have that diagnostic guideline. I just printed up a PDF. They have a small PDF version you can actually get off the website. So I can get that for you if you need me to. And then this is migraine with aura. And so I'm not sure if all my stuff got saved, but we'll see. Anyway, I can make it fast. So migraine with aura. Not everybody who has migraine with aura has an aura every headache, okay? So that's really important to know. And then they only have to have a history of these in the past they only have to have 2 in their history. So if somebody comes to you and they've just had their first migraine with aura and they're describing it, you can't really give it the diagnostic criteria yet, migraine with aura, but you can say probable migraine with aura. You have to rule some things out. Visual, 90% of the patients who have migraine with aura will have a visual aura. There's some really good things you can get off the internet about scintillating scotomas and homonymous hymenopsia. That's another thing, too. There's a huge difference between homonymous hymenopsia, which is normal, and migraine aura, where your left field is blocked on both sides, versus double vision. Double vision is a very bad red flag. So you got to really part and parcel that out and which one it is. A lot of patients think that they have aura because they've got a little blurred vision. We don't put that in the aura bucket in our clinic. If they say, have trouble concentrating or blurred vision, that's not exactly the same as like fortification spectrum, something concrete that lasts 5 minutes to 60 minutes. Some people will have the sensory, and the sensory in the hand that goes up to the face, usually unilateral, can be positive or negative, meaning it can be numbness or it can be pins and needles. And then very rarely people have the language deficit. You can there's a YouTube of a news reporter, and her name was Serena Branson, and she was delivering the news and then got a migraine with aura, and they called it complex migraine or stroke migraine or all sorts of crazy things. But it was just migraine with aura, but her words came out jumbled, and it sounded like she was from Sweden at the time, and they had to cut and go to break. So I show that to all my patients who actually have that, and some of my patients who have that actually cry when they see it. They think something was just wrong with them, and the patients really like it when they feel like they've got somebody else who's going through that. I actually had a patient who works in a professional job, and she said whenever this happens to her, the people at work would make fun of her. That's kind of rude. So I'm going to go on. Okay, so let me see. Okay, I'm going to skip around. So this is the cheat. Now, if you don't have an hour to 2 hours to spend with each and every patient that you're trying to diagnose, this is from Dr. Richard Lipton, and he trademarked this. It's called the ID Migraine Screener. So if you ask patients, in the last 3 months, have you had any of the following? In the last three months with your headaches, did you ever have nausea with one of them? Did you ever have disability or would avoid, bending over to unload the dishwasher if you could? Did you ever have sensitivity to light? So if you had 2 out of 3 of these, then you have a 93% chance of having the diagnostic criteria for migraine. If you have 3 out of all these in the past 3 months, then you have a 98% chance. The only way to get 100% is to do the full criteria. I'm going to go back a slide. So episodic migraine versus chronic migraine. And chronic migraine has gone through genesis over the ages. It's been called mixed, transformed. It's been called a lot of things. But basically, we had to have man-made guidelines of what is episodic migraine and what is chronic migraine. And there is some data suggesting those brain changes that they see on MRI, but how you get more of them, the more chronic your migraine is, that those brain changes happen around day 8 or 9. If you're having 8 or 9 headache days per month, you start to see more of those white matter lesions. That's why I'm very aggressive about prevention in our clinic, and we're also aggressive about close follow-up. So if you're only seeing a patient back every 3 to 6 months who has migraine, what if they went back and forth on the curve and they were doing great and they were only having 3 migraines a month and you were perfect and everything was working, and then 6 months later you see them, they're having 9 or 10. You could have intervened a little bit earlier and also made sure that they're doing a headache diary. Let me see if anything else is important. Okay, so the diagnostic criteria is if you're having more than 15 headache days per month, at least 8 of them should fit the full criteria for migraine, or they would take a triptan or migraine-specific abortive. Also, the difference between chronic migraine and something else, like low-pressure headache, there's a few differences. If a patient says that when they take their migraine-specific medication, like a triptan, once they take their triptan, they're completely pain-free for the rest of the day until tomorrow when they get their other migraine. That's more chronic migraine than low-pressure headache. Low-pressure headache patients typically do not respond well to anything we give them, anything, prevention or attack. And also the people who have low-pressure headache, if you keep on digging, ask specifically, they typically have 0 hours where they're ever pain-free. And so I believe some of my colleagues went over the phases of migraine, which is so important because migraine's not just a headache. People say, oh, it's just a headache, suck it up, just take an Advil. But the thing is, it affects the whole body, like Nate said, family physician over there. So there is the prodrome phase, and I saw this in another slide deck. I like it both ways. But it can be a circular thing because you've got the prodrome that can last hours to days where there might be yawning or frequent urination or just tired or just confused or just a lot of many different things go into that, but that can last hours to days. Most of our patients don't even know this exists unless we tell them. So we have to tell them to start looking for things like this. And then the aura phase, only about anywhere, it depends on what stat you read, anywhere between 15 to 30% will have aura, but they don't necessarily have aura with every single headache. That's the cortical spreading depression. Then you have the headache phase, the pain phase, where the headache gradually builds and it gets up to like an 8 or a 10. But sometimes that's not the most bothersome symptom. Actually, when we're studying attack medicines now, one of the criteria, the secondary endpoints that we're looking at is your other symptom, whether it's nausea or sensitivity to light or fatigue or sensitivity to noise, is your most bothersome symptom gone away after you take your attack medicine? Because when we take the attack medicine, we just don't want you to get better. We don't want you to go from an 8 out of 10 to maybe a 5 and fairly functioning. We really need that to get down to 0. So it's important to ask those questions. And then the postdrome. Some of our patients will tell us that the postdrome, which feels like the migraine hangover or the flu or like a Mack truck hit them, that some people say the postdrome's worse than the migraine itself, but they're relieved. And in between this, it's not on this slide, in between this is what we call the interictal phase. I'm sure I've kind of been in and out, but I know somebody alluded to the interictal phase. And in the interictal phase, we know that the migraine brain is still kind of hyperexcitable, and you can still have photophobia in your interictal phase. And another major symptom you might have in your interictal phase is cephalgophobia, fear of making plans for your next engagement, whether it's just a ball game or it's a wedding, or maybe I don't want to make plans because every time I make plans and then I have a migraine and then I get stressed out and I can't go, and then my husband gets mad at me, so I just won't make the plans. So it affects everybody, their whole entire life, especially the more frequent headaches they have. So it's our job to get them out of headache as often as possible. So I think those of us in this room, especially on this panel, we're very proactive in our prevention and our attack plan. So this is more of the prodrome and the postdrome, all that. And then, so this is it. Perfect, Jay. So this is the sinus headache, yes. So think about the pathophysiology, and after this, I'm going to show a long video that's about 6 minutes, probably during the break, 6 minutes, that came from Roger Cady's office, ClinVest, and the video is kind of old. You would think it's dated, but it's really powerful video. But it shows that we know that migraine is not a vascular disorder anymore. It's a neurovascular disorder. It's a disorder of the brain. It is and the thing is, when you activate that trigeminal nerve, when that trigeminal nerve is activated, you get inflammation in the trigeminal nerve. And the trigeminal nerve, that's the entire face, okay? So some of our patients have pain in their jaw with their migraine. Some people have like a TMJ or a fake kind of like intermittent, like it feels like tooth pain. I had one patient that when her migraine came on, she wanted to go to the dentist every time. It was actually a tooth pain. That's in your trigeminal nerve. So it makes sense that if we're having a sterile inflammation, so migraine is also known as like a sterile meningitis, sterile inflammation of the trigeminal nerve that gets set off and it's on fire and it's inflamed, of course you're going to get rhinorrhea and congestion and ocular symptoms. So there's some studies. They did a retrospective chart review, and more than half the people in that retrospective chart review reported at least one nasal or one ocular symptom. And then in Dr. Richard Lipton's study with the American Migraine Study and the American Migraine Prevalence and Prevention Study, he found out that 88%, and somebody had this in their slides and it was prettier, of the people who said that they had sinus headache fit the diagnostic criteria for either migraine or probable migraine. Most of them were migraine, but the rest were probable migraine. And then Roger Cady did a study in Missouri, and he put an ad in the paper that he just wanted to do an assessment. And his son's in the back of the room, too. I do research with his son. They wanted to do an evaluation of people with sinus headache. Just come into my office, and I just want to do evaluation. So he did a history on these patients, and 48 out of 49 of them met the criteria for migraine. So it's all about education and getting to these patients earlier. Do you have the video on sinus headache, Jay? So this is just a snippet from the long video I'm going to show you later on. Anyway, but everybody stole my thunder with that sinus headache.
As I said a minute ago, all three of the branches of the trigeminal nerve can contribute to the symptoms we see during migraine. If there is an activation of the blood vessels and nerves of the second branch of the trigeminal nerve, the tissues of the sinuses can swell and other nerves can be activated that cause a clear discharge. This commonly leads people to believe they are having sinus headache or a sinus problem when in fact it is part of migraine.
I just like the videos. I've been in colleges and we didn't have good videos like this when I was young. So I'm a very visual learner. And then this is about the neck pain. I think they've all gone into this. We don't even have to show the slide on this, Jay. But so my friend Wade Cooper says that, so you've got the trigeminal nerve, and that's 1, 2, 3 of the face. But in the back of the head, through the C2 nerve root, coming out and bifurcating into the greater occipital nerve on both sides, is the greater occipital nerve comes into the C2 nerve root, and then it meets at the trigeminocervical complex with the facial nerve in the front, the trigeminal nerve. So Wade Cooper says that this nerve back here in the neck should be called the fourth trigeminal nerve, but then it wouldn't be trigeminal. So when patients say, lots of our patients will say, oh, I know I'm getting a migraine when it starts in my neck. And actually 70% of the patients who get migraine report neck pain or neck stiffness with their headaches. So I think it should be in the diagnostic criteria because that's just as high as nausea. So they will report neck pain just as often as they report nausea. I think that's very, very important. So a lot of patients are misdiagnosed with either occipital neuralgia or cervicogenic headache. So I just really think it's important to also ask them on days that you don't have a headache, on days that your pain is 0, do you have neck pain then? Some people do have neck pain every day, but some people never have neck pain when they're not having their migraine. Okay. And then comorbidities, I'm going to try to buzz through as fast as possible if they've touched on it. I knew Nate was going to do a whole slide on comorbidities. And it used to be that when we were treating with prevention, we would look at their comorbidities and would say, what can we double treat? Can we double dip? You know, do they have seizure? Could I do an anti-seizure medicine? Because everything we have is borrowed. And then do they have depression? Can I put them on an antidepressant? I used to practice that way a little bit in the beginning, but now I don't because amitriptyline and venlafaxine, did I say that right? Yeah. Effexor and amitriptyline or Elavil, they only have level B evidence. And in my clinic, I'm in Mississippi. It's the most obese state in the nation. I'm not going to put people on amitriptyline with level B evidence when we've got better things available. So I don't want to make my patients sleepy and gain weight. So I don't really treat their depression with that. We will treat some of their anxiety with some SSRIs, but we're not really treating their headaches with the SSRIs. So you try to co-treat those comorbidities, but you can't always do that. All right. And then I stole this from Dr. Jodick. This is keys to successful treatment of headache disorders. Of course, you're going to rule out the secondary headaches. We'll go over that for a brief second. Then you want to find the primary headache syndrome. And I would just hesitate. Please don't diagnose anybody with tension-type headache or sinus headache unless you've got absolute proof they've got a fever. And then identify the comorbidities and the exacerbating factors and assess their disability and the comorbid features. And then the key is not only to develop, well, in headache centers, we don't just give them a script. We give them about 5 scripts. And we give them a plan. And that plan is everything. That plan is very important. So you and I, we know an NSAID and an antiemetic. We know all those categories. They don't know. And they don't know that they can take a triptan with an NSAID and what a daily medicine is versus a not daily medicine. So, like, for example, I've had patients who came in and they said, yeah, I did it like you said. I took that Imitrex every day, and when I got a headache, I took the Topamax, because they both have X in them, so he got them confused. So you have to spend a lot of times teaching the patient, this is this category, and it's your job to know what this is. Just the same way you would do with insulin, If they give themselves too much insulin, that's deadly. So, okay, this is the Snoops mnemonic. I love this mnemonic. It keeps us safe, and Heather did a fabulous job talking about Snoops. But basically, of course, when somebody comes in, we check their vital signs. If they're not having a fever, look for history of HIV or cancer, immunocompromised. I'm going to go through all these. Postural, we ask about the postural, but that's not going to be the number one thing that's going to tell you that they have a low-pressure headache, and we'll go into that tomorrow. Pregnancy is the 5th P that they've added. Yeah, a lot of Ps. And I think Bake, where are you, Bake? Bake calls it Snoopy, because the Y is for... Yes, exactly. Anyway, so there's lots of bad things that can happen in pregnancy. Pregnancy is a double-edged sword, too, because we typically see that headaches don't ever come out until after the birth of your first, second, or third child. And so that child gets blamed for it as well. So, okay. Also, we've done a neurologic exam, and that's normal. We've gone through the Snoops, and we haven't found anything bad in the history that's going to be any red flags. They have days without headaches. So do you scan them? What do you do? Do you scan them? Do you run a bunch of labs? What do you do? Well, the key is that first slide I gave you about the International Classification of Headache Disorders, that's the way you diagnose migraine, not any test. And so these are some things I've gotten out of. So this is choosingwisely.org, and this is recommendations from the American Headache Society. It says, don't perform neuroimaging studies in patients with stable headaches that meet the criteria for migraine. And then it says, if you do, a CT should only performed in the emergency department. If you're in the clinic, you should order an MRI with and without contrast. And then this is from the same website, but this is the American Academy of Radiology, and they say don't do imaging for uncomplicated headaches. And then I went further and I said, well, what do the emergency physicians say? So I'm going to give you this. It says more of the same, but I'm not going to go into detail. It's all up there. You'll have this in the slides. And y'all will have access to anybody who paid to come to the conference will have access to the slides. We will send those to you. You will also have access. You will also have access to the video when we get that. And then there's my thing. This is the way we treat headache medicine. So, so you can get any kind of headache medicine known to man, and Excedrin. And patients don't read the back of that. They don't know that all those different Excedrins are exactly the same thing. So, general principles of management. You, A, want to get the correct diagnosis. B, you want to educate them. To us in our clinic, education is everything. Make sure they have a headache diary. So what we do is we say, if you're a young person, you probably like electronics, and you can do an electronic diary, like that Curator out there. If you're an old person like me, you probably like paper. I have a paper headache diary. I love it. And we make sure that we have paper headache diaries for all our patients. Hold on. Let me grab it. And some people like to go into way too much history and give you like a 500-page novel on how their headaches were last month. I don't like that. I don't have that much time to read that. I love this one. This is an old Allergan one that we just reprint because I can see 6 months at a time. So if they had a ton of headaches in the beginning and it starts looking light at the end, I'm happy. I try to tell them, sometimes they come in there and it's all zeros because they had 0 headaches. I'm like, don't put anything down. Just leave it blank. Just leave it blank. So I just say, put an H for little headache, mild headache, maybe not even treated that one, an M for migraine, and then let us know if you treated it with an attack medicine, because medication overuse headache is a bad thing. So I'm just going to give you these guidelines. I don't want to go over time. So what's the goal of attack treatment? So obviously we want the pain to go away fast. So the key thing in headache providers' offices is we focus, when we're talking about attack medicine, on non-oral options, okay? And what does that mean, non-oral options? Injectable forms of triptans and NSAIDs, but injectables, nasal sprays, any other better delivery system that you can get, because the GI system, Dr. Sheena Arora did a lot of work on the GI system of migraineurs, and she found out that during a migraine attack, you have gastric stasis, but you even have gastroparesis in between migraine attacks, intraictally. So we want the pain to go away fast. We also want all the other associated symptoms to go away fast. We want them back to fully functioning. Every year, transforming from episodic migraine to chronic migraine, we all have, whoever has episodic migraine has a 2.5% chance that they're going to transform to chronic migraine. If you don't get your patients down to zero when they're treating with an attack medicine, if their pain doesn't get down to zero, that more than doubles their risk of getting into chronic migraine. So you have to be, we're very measured in our approach to how well is your headache medicine working. If it used to be when I was first training in headache medicine, we walk into the room, how's your headache plan going? Oh, it's great. How's your, Relpax, Maxalt, whatever? Oh, it's great. But if you ask the questions a little deeper, you say, how long does it take for you to be pain zero, and does it work every single time? You might get a different story. So especially if they only got 4 Relpax, they might say, well, I hoard them all, and I don't take them until the very end, and they don't work. Or they think a headache medicine works great. They'll say, it works great. 6 hours and a nap, and I'm good, But we really want them to be pain-free within 2 hours. That's actually how we measure it. Pain freedom, pain zero, not pain 1, not pain 2, pain-free within 2 hours. That's how it's measured when we're studying these drugs for the FDA. But also, we don't want it to rebound that same night. We don't want them to have to repeat the dose if possible, and we don't want it to recur the next day or the next day. So migraine, think of it, it's a 2-day or a 3-day attack. It's a 48 to 72-hour attack. The goal is to not let it keep on coming back, because then you get into that central sensitization. All right. And I probably have gone through a lot of these. This is why we do non-oral, and I think Mr. Yale over here, Chris Godchalk, says, if you come see me, you never get an oral medicine. Yeah. He doesn't do any oral attack medicines. And there's so many good things out there. If you look at the PK profiles of how fast a medicine can get in, you want that medicine in the bloodstream as soon as possible. So if you can, all of our patients, they might have an oral triptan or oral NSAID that we give them, but we always give all of our patients a non-oral option. What if they vomited that medication? So we want them to have that, because I'm not on call on weekends and nights, and I don't want them to go to the emergency room, but I want them to have the tool basket that they need to stay out of the emergency room. All right. So this is level of evidence that I think Nate went through, and all the other guys that came before me went through. So I've got some things highlighted. And level A evidence means that it had at least one large, it has to have about 1,000 in it, one large placebo-controlled randomized clinical trial, okay? And level B evidence might have 2 small trials, and maybe it works. Level C says the evidence is inadequate or contradictory, and I think level D and level U are saying there's a lot of evidence that it does not work. So you want to be in the A or B category. Now, I was going to say a couple of things. So all the triptans are level A evidence, and then you've got your aspirin and acetaminophen, but if aspirin and acetaminophen were working for your patients, they wouldn't be there to see you. So the only NSAID that's not an over-the-counter is diclofenac, and we use diclofenac a ton in our office. There's actually a dissolving powder form of diclofenac that peaks in the bloodstream in 5 minutes versus, taking 2 hours to work if it's a pill. So that's a really good option. The Stadol nasal spray, anything I've gotten read, it's for please do not ever use this, because these are not great medicines for migraine. We know specifically that they actually increase your chances of getting to chronic migraine and making everything that we do futile. So every single patient that has no contraindications, I give them at least one triptan, usually an oral and a non-oral. I give them diclofenac to take with it, And then I also give them either prochlorperazine, which is compazine, or Reglan. And the reason is both prochlorperazine, which is IV compazine, and IV metoclopramide or Reglan, those both have level B evidence that they work to shut down migraine. They've got great evidence in the ER as well. And so I don't give Phenergan necessarily because I don't want people getting sleepy. And then Zofran doesn't really work on shutting down the migraine. So our 3-drug cocktail is a triptan plus an NSAID plus an antiemetic. And we tell them to take that compazine whether or not they're nauseated at all because it's most likely going to work. Another trick we use is if they can go to sleep, we'll tell them to take 25 milligrams of liquid Benadryl with that, and that really helps. And then a friend of mine at one conference told me that rectal suppositories of compazine work great, but that's really hard to get your patients to do that. And the butalbital, level C, you'll see the opioids and butalbital. Opioids have such high risk of causing rebound, even if you're only taking them once or twice a month. And butalbital, does anybody know the brand name of butalbital combinations? Okay, so that's the F word in headache medicine. So Fiorcet's the F word in headache medicine. We actually, so at the school where this was developed, it's Montefiore School up in New York at Albert Einstein, and it's a headache center. They developed Fiorcet, and it is not FDA approved for migraine, by the way. And so Fiorcet, they developed it about 30 years ago. Now they actually put patients in hospital to get them off of it. So yeah, so avoid that at all costs. All right, and so this has a lot of words on it. So this is medication overuse headache. So basically it's a secondary headache disorder caused by using too many analgesics. So what happens is when you're young, you start off, you've got a couple of headaches a month, and you're using Excedrin a couple times a month, and then it's a couple times a week, and then it's a couple times a day, and it just becomes this big cycle. The problem is it gets you into chronic migraine very fast. So it's kind of difficult when you're working with somebody who already has chronic migraine and medication overuse to try to get them to use less medicine. So there's actually, but we do know that opioids are the worst. Opioids and butalbital are the worst for this. Triptans can cause medication overuse headache, but I'd rather my patients use too many triptans than use any narcotics at all, period. Because I know my patients are not abusing their triptans for fun. And then also, I did not know this, but Ashley Haddle will tell you that people who have cluster headache can get rebound if they're taking more than like 2 or 3 Imitrex injections per day. So the more Imitrex injections they take, the more Imitrex injections they need. And she'll talk to you about that. But we're actually involved in a clinical trial. Also, a lot of patients come in on Excedrin and BC powders, and that has caffeine in it. So if they're taking 6 or 7 Excedrin or BC per day, don't stop that automatically because then they'll never come back. If you don't want them to come back, just stop it automatically. But you need to really wean that slowly to get all that caffeine out of their system and then assess the rest of their caffeine. So we're in this clinical trial. This is kind of a neat trial. We're not studying a drug. It's a patient-centered outcome trial, and it's the medication overuse treatment strategy trial, and it's run by Dr. David Dodick and his partners out at the Mayo Center in Scottsdale. And basically, we're taking any of our patients who are taking 3 or 4 BC powders or Excedrins or triptans per week and randomizing them and seeing and for a different strategy, whether or not we're going to put both of them on prevention no matter what. But one arm of the treatment strategy gets switched to a different attack medicine, and the other one is told nothing, and they can see if they can just wean off eventually on their own. So it's pretty interesting. And how many people do we have in that trial? What? 25. Okay, so yeah, this is going to be a 3-year study. Nate has patients in this study, correct? Yeah, so it's a pretty neat study. So, okay, he's just trying to one-up us. Okay. All right, we're gonna. You're going down. Okay. All right. So, the American Academy of Neurology and the American Headache Society have looked into who deserves preventive treatment. When do you think about preventive treatment? At our center, probably if they come through the door, we're going to put them on prevention. I would say, with children, we do treat children. Our youngest patients are 2 and 3 years old. But with children, we're a lot more gingerly, and we might just put them on, a lot of education. CBT is number 1 in children. But vitamin B2, 400 milligrams, it has level A evidence. So we put everybody on vitamin B2. And that's the nutraceuticals talk, and I don't think anybody's given that one. But so if you're having, they used to have this rule that if you're having 3 days per month with severe disability, that you deserve prevention. I'm thinking, so the person with 1 severe disability day per month doesn't deserve prevention? That's 12 times a year that they're going to miss work. So if I can't give you an abortive medication that will make you pain 0 in under an hour or 2, and we can't, or say you've got a visual aura or you're vomiting and we can't get you under control, and you're consistently having to call in work at least 1 day out of the month, then we're going to put you on some prevention. There's different goals. Prevention is not just to decrease the frequency. A lot of times it will decrease the severity, and it allows your TAP medicines to work better. A lot of patients will say, I tried this, or I tried that, or I tried this. I'm like, well, you haven't tried it with prevention, so we're going to try it again. So, and this is more level of evidence on, this is the preventives, and the way I did it this way with my highlights is I don't really put people on Depakote anymore just because of the side effect profile and the weight gain and getting hairy and women of childbearing age, and we're treating women of childbearing age every day. So, and we do tell all of our women of childbearing age, please be on prenatal vitamins and don't get pregnant on the drugs that we're putting you on, and come and talk to us before you decide to do something like that, get pregnant. But sometimes pregnancies happen accidentally. And propranolol is my favorite beta blocker that's used for prevention, but it has a lot of side effects too. And it used to be that we were taking all these medications. Where am I? Okay, there they are. It used to be that all of our medications for prevention were borrowed. Topiramate, they found out from the seizure people that it made their seizures, their headaches better or go away. And then the beta blockers, borrowed from the blood pressure category, and then the antidepressants. But recently we've had, and then also onabotulinum toxin A, that's only for chronic migraine. I was supposed to put that in red. I hadn't done that yet. That's going to happen by the end of the day. Onabotulinum toxin A, which is Botox, that's borrowed from plastic surgery. But now we have a new class of medications out, the CGRP monoclonal antibodies. Who's giving that talk? Nate? Okay, Nate's giving a great talk on that tomorrow, and we're very thrilled because this is the very first time in the history of migraine that we have a prevention that was designed based on what we know in science with the pathophysiology of what's going on in migraine. So you'll hear all about that tomorrow, or you can go in that exhibit hall, and a lot of people will tell you about it. So we're excited about that. Those 3 over there, which are arenimab, fremanezumab, and galcanezumab. Those are all either monthly or quarterly injections that you can do at home. And then they're studying another one that's coming out that's an IV. And then Nate went through this. Like I told you, I'm not going to really do a lot of amitriptyline. Sometimes it works. I have had some great successes on amitriptyline, but I'm not necessarily going to put somebody on level B evidence when we've got level A evidence that's known to fight migraine. And then level C evidence, the lisinopril on here, so it's a catch-22. I use a lot of lisinopril because it's my favorite little blood pressure medicine, but it's because I want to put them on a triptan, and if their blood pressure is borderline, I want to keep their blood pressure under control so that I can give them a triptan for an abortive. And you got to think about that with your NSAIDs as well. And the Bistolic that's on there, that's Diamond Headache Center. Dr. Merle Diamond, that's one of her favorites. And the Candesartan that's on there, it's hard to get that covered, but that's Wade Cooper's favorite. And then the lamotrigine, I just wanted to say something about that. It has poor evidence, but it is written up in some of our books. It's studied for prolonged migraine with aura. So if somebody has like aura that lasts for like 10 days, you might try lamotrigine. And I have 1 success or 2 successes with cluster headache and lamotrigine. All right. And so this is urgent care in the emergency department. I have a great PowerPoint presentation just on the emergency room from Mia Menon, and she just won an award with the Diamond Headache Center Foundation. But basically, IV, hydromorphone, any of those narcotics, they actually did a study of IV hydromorphone versus prochlorperazine. They shut the study down early because the compazine won like so much better than the other. So the compazine has the best evidence. If you go into an ER, and that's another thing, was we're going to give our patients these cards that tell them exactly what to ask for in that ER. And if you ask for something that's not a narcotic, you might get better treatment in that ER. So if you go in and say, I need a liter of fluids and pre-treat me with some Benadryl and give me some prochlorperazine, that has the best evidence for shutting down migraine. And then the second best evidence is metoclopramide. You wouldn't use those together. Both of those can cause the dystonic, the akathisias. So you always want to pre-treat with Benadryl. There's no evidence that Benadryl shuts down migraine, but we want to pre-treat with that. Ketorolac has some good evidence. The IM PO ketorolac does not work whatsoever in headache medicine. I never use the oral Toradol. We only use IM or IV. There's some decent evidence of the sodium valproate for shutting down a headache. The thing is on that is you're supposed to give it IV push really fast too, like over like 5 minutes for it to work. And then the magnesium, it's got some evidence basically in migraine with aura. And then what I wanted to say about the dexamethasone is dexamethasone has zero evidence that it shuts down migraine, but it has great, about a 25% chance of decreasing the rebound if you leave the ER or the urgent care. So if we get your headache down to zero with some of this other stuff, and maybe you don't want them to come back to the ER tomorrow or the next day, you can give them some dexamethasone, and that does decrease the rebound on that. And Bake, you're going to be talking about that later on. Okay. I'm sorry, his name's Ira. Okay. So, and I'm not going to go into detail on this either because Chris is giving a talk on, we're actually going to give a procedure workshop tomorrow. And we have some live patients, and we have some models that Allergan have given us some dummies. So we're going to do peripheral nerve blocks, trigger point injections, and we have an IV infusion clinic, and most of my colleagues, do you do IV infusions? Yeah, we all do IV infusions. And then sphenopalatine ganglion blocks, you can learn how to do that tonight at 6:30 here. And then Botox, not acutely, but Botox is a prevention for chronic migraine. Okay, and I just threw this up there really fast. So I sent a lot of patients to Dr. Tiffany Scarf up here. So you can do, I can do DHE in my clinic, but unfortunately I can't get reimbursed for it. And it's better not to do just one dose of IV DHE or IM DHE. It's better if you kind of put somebody in the hospital for 5 days, give them 11 milligrams over 5 days. You're able to detox them from possibly their triptans or whatever they're abusing and get them stable. We start off by giving them like a 0.5 milligram of IV DHE, and we pre-treat that with an antiemetic first with Benadryl. And if they tolerate that without vomiting, then we give them 1 milligram the next dose, and then we do that every 8 hours. And then I would add some Toradol with it, and you can add steroids for discharge, but don't add a narcotic with it, because every time you add a narcotic or an opioid or a barbiturate, you actually make your prevention ineffective. And I have some patients who come see us, and I tell them, I'm not going to do any narcotics for you, no narcotics. And I tell them, whoever's prescribing your narcotics, like they might be getting narcotics for their low back pain. So I have patients who are on narcotics every day for their low back pain. And I say, that's great, but your brain can't differentiate the narcotic that it's for your back pain and not for your head. And we have evidence that shows that the more narcotics that are in your system, your brain actually has chemical changes, and it cannot compensate anymore. So if somebody wants me to do Botox for their chronic migraine, I tell them I'll do it, but as long as you're on those opioids, I cannot guarantee that you're going to have much success with it. I set expectations really low when I do that. Okay. All right. And I don't want to offend anybody in here, so I have lots of places where I send patients that I can't fix them. If I can't fix them, I'll get you in somewhere. I can get somebody into Diamond Headache Center in a couple weeks. I can get them into Mayo Clinic in Scottsdale. If I can't get somebody to not have a headache all the time, I'm trying to get them to some of my colleagues and friends who can help. And so we never stop. We always will send you somewhere. I tried to send a patient to Jefferson Headache when she was 17, and they said she was too young because she wasn't 18. So we took her to Roger Cady's office, and that worked out really well. And Montefiore, that's where Fioricet's made. No, just kidding. And these are some things that are on the horizon. I put them on there. You can go look them up. There's lots of great new medications coming out for headache, and everything needs to be studied in pediatric studies. And then the GPANTs are like CGRP blockers, but they're a small molecule pill, and they're studying those for abortive and prevention. I think we're studying some right now. And we also have devices. So devices get FDA cleared, not FDA approved, because you basically have to prove that they're safe. You don't have to prove their efficacy quite as much. And when I redo the slides or finish the slides, I'll have pictures of all these. I'm sorry I don't have them on there now. But Cephally looks like kind of like a little Star Trek TENS unit that you put on your forehead. Is any of my colleagues using that in their clinic? Cephally device? Okay, he is. And then eNeura, what I like about eNeura, it was originally FDA approved for the treatment of migraine with aura, treatment, not prevention, and it's safe in pregnancy, so I love that. It's a transmagnetic stimulator, and they've changed the device a little bit, but it's this thing you put on the back of your head, and you just hit snap, and it just sends a little electrical current, and it's supposed to stop that cortical spreading depression. So it's really neat, and I think it can be used as many times a day as prevention as well. Maybe we'll have them here next year. And then we do have the GammaCore NVNS device, and in my disclosures, I do speak for that company. So that is a device. You can find it in the room over there, and it's so the vagus nerve is located right on top of your carotid artery. And if you put this on your vagus nerve, well, we know the vagus nerve goes all in the thorax and the abdomen, but it also goes directly into the brain. And there's lots of evidence that it sends afferents up into the brain to shut things down, including like decreasing glutamate and stopping cortical spreading depression. So it was first FDA approved here for the attack of cluster headache, and now it's used also FDA approved for the attack of migraine, and it's also being studied in prevention. So, and the good thing is with these devices, no drug-drug interactions, and they're all relatively very, very safe. Okay, and this is just some resources that we like, and now I'm going to introduce you to Ashley Haddle.